Bismillah ar-Rahman ar-Rahim wa salatu wa-salam ala Rasulillah. Thank you very much for the introduction, and thank you, Dr. Saeed al-Shayban, and the organizing committee for inviting me for this meeting. So, bone marrow evaluation in lymphoma. Bone marrow infiltration is frequent in lymphoproliferative disorders. Therefore, before starting treatment, patients are staged with the Ann Arbor staging system for prognosis and treatment planning. In addition, bone marrow can be the primary site of the disease, and the entities such as bone marrow, liver, and spleen, BLS type of large B-cell lymphoma, and primary lymphoma of bone marrow have been implemented. And the reason why bone marrow examination is important in lymphomas is because it will advance the case to stage 4 when bone marrow involvement is detected. In the current medical practice, bone marrow involvement is assessed by either pathological and/or radiological evaluation. Bone marrow biopsy is the most direct method of detecting lymphoma infiltration, but it is an invasive procedure which is accompanied by several complications such as pain and hemorrhage. On the other hand, PET scans is a non-invasive examination that can comprehensively evaluate the state of bone marrow with extremely bone marrow biopsy is the most direct method of detecting lymphoma infiltration, but it is an invasive procedure which is accompanied by several complications such as pain and hemorrhage. On the other hand, PET-CT is non-invasive examination that can comprehensively evaluate the state of bone marrow with extremely high sensitivity in detecting bone marrow infiltration of lymphoma. Therefore, many clinical institutions put forward the idea of replacing bone marrow biopsy with PET scans as the first choice in the diagnosis of lymphoma involvement of the bone marrow. Okay. However, many other practitioners and researchers share different opinions. Relevant research indicates that PET scans cannot replace bone marrow biopsy in the diagnosis of bone marrow involvement by diffuse large B-cell lymphoma or follicular lymphoma, and the accuracy of PET scans in detecting bone marrow infiltration is unsatisfactory. And the bone marrow evaluation remains the standard of method in bone marrow evaluation for lymphoma. Here are two studies to compare PET scan evaluation with bone marrow pathological assessment. The first one included 153 cases using FDG uptakes, and it showed an average sensitivity, meaning missing almost half of the cases with good specificity. The second cohort included 80 cases using fluorine 18 radioisotope FDG uptakes. It demonstrates excellent sensitivity, but this in trade-off the specificity, as many negative cases labeled falsely as positive. Now moving to the bone marrow sample. So the bone marrow procedure is unique as it is of 2 steps or sampling procedure. The bone marrow aspirate, which collects the liquid component of the bone marrow, and the core biopsy, which collected the tissue component. And each one is utilized thoroughly and differently. The bone marrow aspirate is the source for bone marrow smears, bone marrow clot section after left until the aspirate got clotted, for flow cytometry analysis and karyotyping, fish, and molecular testing. While the bone marrow trephine biopsy is the source for H&E histological section, where immunohistochemistry staining can be performed, and touch imprint, and the touch imprints. The trephine biopsy can be utilized also for fish and molecular testing if needed. Here are the bone marrow slides that you received for evaluation. The assessment of cytological details can be carried out using films of the aspirates or the imprints from the trifine biopsy. Please remember, peripheral blood smears are very valuable for cytology assessment as well. Histological features can be assessed using sections of either the trifine biopsy specimen or the aspirate clot. The pattern of infiltration can be only fully assessed using section from the trifine biopsy specimen. This is a nice diagrammatic scheme of what is the best source for assessment. For example, architecture can be best assessed from the core biopsies followed by clot section. IHC only can be assessed by clots and core biopsies. Morphology assessment is best assessed by aspiration and touch imprints, and flow cytometry only by bone marrow aspirate sample. For bone marrow evaluation, it can follow either one of two ways. Either a lymphoma diagnosis is already made and the bone marrow is performed for staging. You can call this the guided route. Here you can look for the specific features and phenotype from the diagnostic site and base your evaluation on that. The other path is when the bone marrow is the primary site of the disease or lymph node sampling is not accessible. Bone marrow infiltration by malignant lymphoma is not a random process, but is influenced by characteristics of the neoplastic cells as well as the microenvironmental features, leading to a characteristic pattern of marrow involvement for many lymphoma subtypes. And here's a summary of what you can do to analyze bone marrow, and I will suggest like an algorithmic approach or what I do routinely in my cases. So I start first with the cytology features of the lymphoid cells, looking for the size, whether the cells are small, medium, or large, then going from inside outwards, what is the nucleus shape? Is it round, cleaved, cerebriform, flower-like, or irregular? Is the chromatin clumped or open? Is there prominent nucleolus, or whether one or multiple, or there is no? How about the cytoplasm? Is it scant or abundant? Is there granules or vacuoles in the cytoplasm? Is the cytoplasm showing projections, and whether these are circumferential or polar? Finally, assessing the sample quality. Is it particulated or non-particulated? That may indicate a dry tap. In some cases, there will be no abnormal lymphoid cells present, and this will require the bone marrow biopsy for evaluation, and it will be the major source for your assessment. Next is the bone marrow trifine biopsy. Starting with the patterns, 6 major patterns can be seen in lymphoma involvement in the bone marrow, either alone or in combination. The first one is interstitial infiltration. That indicates the presence of individual neoplastic cells interspersed between hematopoietic and fat cells. Bone marrow architecture will not be effaced or distorted. The second one is nodular pattern, which indicate the presence of non-paratrabecular, round or oval aggregates of lymphoid cells with well-defined borders. They sometimes form or colonize lymphoid follicles. The paratrabecular pattern indicates that neoplastic cells are immediately adjacent to the bone trabeculae. The fourth one, random or focal involvement, indicates irregular distributed foci of neoplastic cells separated by residual hematopoietic marrow cells. The aggregates of neoplastic cells have no particular relationship to bony trabeculae and have irregular margins. Intrasinusoidal infiltration indicate the presence of neoplastic cells within sinusoid, either alone, which is very rare, or in association with other pattern. And this is usually very hard to detect unless very pronounced without IHC testing. Last pattern is the diffuse, or sometimes called packed, indicates extensive replacement of normal marrow elements, both the hematopoietic cells and fat cells, and indicating severe effacement of the bone marrow architecture. Next is the composition of these infiltrates, whether it is lymphocytic or mixed infiltrates that composed of histiocytes, eosinophils, plasma cells, and lymphocytes. Similar to the bone marrow aspirate assessment of the cytology feature, you can assess the cells. The cell size, the nuclear shape, chromatin, nucleoli, cytoplasmic features, as well can be seen here in the trifine biopsy. Bone marrow fibrosis can be detected, and it is usually reticular fibrosis. Collagen fibrosis is not common in lymphoma involvement. After morphology assessment, immunophenotypic analysis of the lymphoma cells by flow cytometry, starting with lineage identification. So am I dealing with B or T using CD3 and CD19, then checking the clonality by kappa lambda light chain restriction in B cells, or CD4, CD8 ratio skewness in T cells. Based on that, you can extend your panels. And B cells, I suggest you start with the top line. Then if CD5 is positive, I use panel in the second line. If CD10 is positive, or both CD5 and CD10 are negative, I analyze with the third line. In some cases, you may need to analyze the cells with the fourth line of antibodies. Similarly, for T cells, I usually analyze the top panel. The second panel when granular lymphocytes are seen or suspected. The third and fourth line are add-ons for a couple cases as well. Lymphoma cells phenotype can additionally be assessed by immunohistochemistry. Similarly, B cells and T cells panel are very important, and some lymphoma subtype can only be determined by IHC testing, as you can see here in the suggested panels. When Hodgkin lymphoma is suspected, these are the markers that are useful for identification and assessment, hopefully leading to the determination of the diagnosis. Next are the genetic and FISH studies. They are very important in assessing bone marrow involvement by lymphoma. I strongly advise to do karyotype in all cases, especially B and T cell lymphomas. For FISH, as Dr. Swaydan just mentioned and discussed, CLL cases have a specific panels. And similarly for B cell and T cell lymphomas, they have long list of probes. But sometimes one diagnosis is determined or very suspected, so requesting the confirmatory probe rather than doing the full panel is recommended. For molecular and NGS, Dr. Swaydan has covered that very well. Just I wanted to highlight a point that with the progression in the molecular testing and the new reports that revealing defining abnormalities, so it is better to include molecular testing and NGS for your assessment. Now I want to share with you some facts on the bone marrow evaluation in lymphoma. Overall, infiltration is probably more common in B-cell lymphomas than in T-cell lymphomas. And among B-cell lymphomas, bone marrow infiltration is more common in low-grade than in high-grade lymphomas. Focal infiltration is more common than diffuse. On the other hand, diffuse infiltration is relatively more common in T-cell lymphomas than in B-cell lymphomas. Trifine biopsies are generally more successful at detecting marrow infiltration by lymphoma than bone marrow aspiration. Focar et al. Studies 93 lymphoma cases and showed trifine sections and aspirate films were both positive in 79% of the cases. Trifine biopsies only were positive in 18% of the cases. Films only were positive in 3%. In another study with 102 non-Hodgkin lymphoma cases with bone marrow involvement, trifine biopsy sections were positive in 94% of the cases, marrow clot section in 65, and marrow aspirate films in 46. And among these, only 6% of cases, they are showing positive films alone. In addition, bone marrow infiltration may be concordant, meaning the same histologic type and grade as seen in the lymph node or elsewhere, or can be discordant and showing a different histologic type or grade. The frequency of discordance has varied between 16 and reaching up to 40%. I will mention here some points to keep it in mind. To avoid false negative results, the performance of a unilateral or bilateral bone marrow trifine sample of adequate size with a minimal length of 1.5 centimeter is regarded mandatory for initial or response evaluation. Keep in your mind also variants, whether morphology variants, as you can see in mantle cell lymphoma, follicular lymphoma with plasmacytic differentiation, small cell variant in number of T-cell lymphoma subtypes, such as ALCL, peripheral T-cell lymphoma, and TPLL. In addition, immunophenotypic variants are also important to keep in mind, such as CD4 positive T large granular lymphocytic leukemia, CD10 positive hairy cell leukemia. Also, lymphoma cases can be double positive for light chain. Remember, hematogones are also negative for light chains. Also, double negative CD4 and CD8 T cells are seen in autoimmune lymphoproliferative syndrome. So keep these variants in mind always when you assess bone marrow for lymphomas. Always remember, necrosis is a bad finding, and HLH can be the major presentation or pathological finding in some lymphoma subtypes. Also, you should always keep up with the new updates in the field, like the new classification from WHO and ICC classification are essential. Also, the development and advances in flow cytometry markers that like newly reported or published. Also, molecular advances as well. I will talk briefly about some advances in flow cytometry. Flow cytometric assessment of CMYC is an assay that we developed and published in our laboratory at Case Western Reserve University. It is a very powerful assay for accurate quantification of CMYC in lymphoma cells. This is an 87-year-old man with Burkitt lymphoma with circulating lymphoma cells. The top plot is based on CD19 positive gating, and it revealed 82% of the cells are positive for CMYC. While when we gate based on CD19 positive, CD10 positive gating, the middle plots, 100% of lymphoma cells are positive for CMYC, and almost negligible percentage is positive in the CD19 positive, CD10 positive, CD10 negative cells. The bottom plot is for CD19 negative cells, indicating T cells, and show no reactivity for CMYC. And you can compare it with the CMYC expression by IHC, which was estimated to be 95%. This is another case, 42-year-old man with follicular lymphoma. The top plot is based on CD19 positive gating, and it revealed 8% of the cells are positive for CMYC. While when we gate based on CD19 positive, CD10 positive gating, the third plot, 14% of the lymphoma cells are positive for c-Myc, and 0% is positive for the CD19 positive, CD10 negative cells. c-Myc expression was estimated 5% by HC manual count. So it is a very powerful and accurate assay, and we have shown that it correlates better than the IHC when you compare it to the FISH results for c-Myc rearrangement, whether break apart or fusion abnormality. Next, for the TRBC1, this is during the TCR gene rearrangement, a mutual exclusive selection of two cell receptor constant beta chain occurs. This allows for the flow cytometric assessment of constant beta chain monotibia as a surrogate of clonality. And this is the principle behind this flow cytometric antibody. If, like, to simplify it, it is like similar to kappa lambda in B cells. These are examples of cases with large tumor clones, and they show clearly a monotypic T cell receptor beta chain constant region expression. A and B plots are two cases of Sézary syndrome, gated based on CD3 and CD4. The first case is monotypically positive for TRBC1, 99% of the clone, while the other one is completely negative. The C and D figures are two cases of TLGL leukemia. Similarly, the first one is monotypically positive, and the other one is negative. Not even in cases with large clone, even in cases with small clones, this marker is very useful. The A and B figures is cases of peripheral T-cell lymphoma NOS. And the first one you can see gated based on CD4 positive and CD8 dim, the blue population, is clearly monotypic for TRBC1. For C and D figures is for a Sézary syndrome case that failed to reveal the subpopulation with restricted TRBC1 expression in the C plot. And this is because it was gated only on CD3 and CD4. But as you can see in the D figure, when gated by CD7 negativity with CD3 and CD4 gating, apparent absence of expression of TRBC1 was detected. I will conclude my talk with 4 interesting cases that can show how to apply like an algorithmic approach to assess bone marrow evaluation for lymphoma. Case 1 is a 70-year-old female with left axillary swelling, presented with, as you can see, leukocytosis, anemia, and thrombocytopenia. Lymphocytes in the bone marrow aspirate are small, with scant cytoplasm and clearly cleaved nuclei. Even a complete crack making it bilobed cells are seen. In the tissue, a nodular infiltrate is detected with major paratrabecular involvement. And cells in the trifine are also small in size with very scant cytoplasm. The flow cytometric analysis revealed all B lymphocytes are kappa-restricted cells and appear mainly negative for CD10 with a small bulge highlighted in green color, indicate a subset of lymphoma cells are CD10 positive. Similarly, by IHC, the lymphoma cells are CD20 positive, BCL2 positive, and PAX5 positive, highlighting the nodular and paratrabecular infiltrates. With very small proportion of lymphoma cells are positive for BCL2, BCL6, and CD10. FISH was done and showing positive for rearrangement of IGH BCL2 fusion. And the case was diagnosed as follicular lymphoma, low grade. And the lesson to remember from this case is that it has been published that downregulation of CD10 is seen in the leukemic phase of follicular lymphoma and also in GI follicular lymphomas. Case 2, 70-year-old male patient with lymphadenopathy. CBC showed leukocytosis due to lymphocytosis and anemia. The cells are predominantly large in size with clearly prominent nucleoli. You can see it here in the aspirate smears. The trifine biopsy showed diffuse infiltration of bone marrow spaces. The flow cytometric analysis revealed all B cells are CD5 positive and lambda restricted with strong CD20 and almost negative CD200 reactivity. You may notice from the CD45 side scatter plot, the top left plot, that these lymphoma cells are higher in the side scatter compared to the background T cells, confirming their larger size. This is maybe determined more precisely if we plot it forward scatter versus the side plotting. IHC confirmed the diffuse infiltration by CD5 positive B cells with positivity for cyclin D1. FISH was positive for IGH cyclin D1 fusion, and the case was diagnosed as mantle cell lymphoma pleomorphic variant. Case 3, this is a 29-year-old male, known case of bronchial asthma, presented with epigastric pain associated with vomiting and diarrhea for 1 week, positive history of subjective fever, weight loss, and night sweating with progressive abdominal distension. His CBC findings show leukopenia, anemia, and thrombocytopenia. No abnormal lymphoid cells are seen in the peripheral blood or bone marrow aspirate. Also, flow cytometric analysis was negative for any abnormal lymphoid population, so they are not helpful in this case. In addition, the lymph node core biopsy result was suspicious for lymphoproliferative disorder. Excisional biopsy was recommended, but the patient's situation wasn't fit to do an excisional biopsy. So the main focus was to be done on the bone marrow core biopsy. So this is the trifine biopsy. You can see multiple medium-sized nodular infiltrates are present, some with central necrosis. Higher magnification show that these infiltrates are composed of large and very pleomorphic cells, and many show multilobulated nucleoli with prominent nucleoli mimicking anaplastic look. Some RS-like cells are also noted. Also, if you can see, these infiltrates shows a rich surrounding of reactive cells, including lymphocytes, eosinophils, plasma cells, and histiocytes. CD20 appeared variable and partial, but in some spots, it showed very strong positivity. Similarly, staining pattern seen by PAX5. It is variable, ranging from weak to very strong positivity in these infiltrates. While CD30 is very strong and uniform, and even with accentuation and Golgi, the staining is noticed. These tumor cells are negative for CD15 and positive for CD45. and appear positive for c-Myc with variable proliferation index ranging from 30% and reach up to 80%, as you can see in this spot. And strongly positive for EBER, matching the CD30 staining, and estimated to be in 80 or more of the malignant cells. Karyotyping showed normal diploid karyotype, and FISH analysis for B-cell lymphoma panel was negative. Virology testing have shown that EBV PCR testing was very positive and show a very high viral load. So the case was diagnosed as EBV positive diffuse large B-cell lymphoma NOS, polymorphic pattern, and I believe we will have in the afternoon a session about EBV lymphoma, and this should be covered there. The last case is a 70-year-old male referred to hematology for anemia and lymphocytosis, suspecting CLL. His neutrophil absolute count was within normal limits, and platelets are also within normal count. Peripheral blood showed lymphocytosis, with lymphocytes displaying small, mature lymphocytes with slightly abundant cytoplasm and very granular. Moving right away to flow of cytometric analysis. So 70% of the T lymphocytes are found positive for CD8, CD7, and CD16, and negative for CD56. And positive for CD2, CD11C, and CD57, and negative for CD5, the most important aberrancy in this case, and negative for CD26. This phenotype is very specific for TLGL leukemia. The case was positive for TCR beta and TCR gamma gene rearrangement, although karyotype wasn't that showing a good number of metaphases, but one cell show normal diploid karyotype. FISH analysis for T-cell lymphoma panel was negative. The triphyline biopsy showing similar results. So the case was diagnosed as TLGL leukemia. And by this, I conclude my presentation and acknowledgement for the people who helped for this presentation, and thank you very much.